Hi, Gareth, and everyone listening to this presentation. My name is Oscar, and the paper I'm presenting on is The Impact of Advanced Care Planning on End-of-Life Care in Elderly Patients, Randomized Controlled Trial. This paper argues that currently the healthcare services provided to patients approaching the end of their lives do not sufficiently attend to the wishes of the patients. This is largely due to the absence of any prior knowledge about the patient's desires regarding their future medication treatments at the time when they lose the capacity to make decisions, which results in the patients being treated in a way that they would not have chosen. In order to deal with this issue, the paper argues that, along with making progress in improving palliative care, development and expansion of advanced care planning may also assist the patients in planning for their later care services in advance when they are still capable of making these decisions. Hence, the aim of the present study is to explore whether coordinated advanced care planning will improve end-of-life care. In particular, the authors made the following three hypotheses. Firstly, advanced care planning will improve end-of-life care. Secondly, advanced care planning will improve the perception of the quality of care. Thirdly, advanced care planning will reduce the levels of adverse psychological effects among relatives of the patients. 871 patients were assessed for eligibility. After applying the exclusion criteria, which include that patients must be more than 80 years old, must speak English, be legally competitive, had families, had no prior advanced care planning arrangements, and must not be expected to die or be discharged from the hospital in the immediate future. The 309 remaining participants enrolled in the study. Then, participants were split into two groups, which was an intervention group and a control group. There were approximately equal number of participants in each group. The control group received only the usual care that the hospital provided. The intervention group, on the other hand, also received the usual care, but in extra, they undertook the coordinated advanced care planning, whereby some professionally trained non-medical facilitators, in collaboration with the treating doctors, discussed and documented the patient's wishes on their future choices of health care at a time when they lose the capacity to make decisions for themselves. This was done in concordance with making reflections on the patient's goals, values, and beliefs. Outcomes were measured through quantitative data. The primary outcome measure was the extent to which the wishes of those patients who died were acknowledged and respected by their doctors. There were two secondary measures. One is the patient satisfaction of the hospital stay, and the other is the psychological impacts on the relatives of those patients who died. The results show that all three hypotheses were supported. Firstly, our primary measure shows that receiving advanced care planning results in a higher compliance with the patient's wishes among the deceased patients. Their end-of-life wishes were acknowledged and respected in 25 out of 29, or 86% of patients in the intervention group, compared with only 8 out of 27, or 30% of those in the control group. Secondly, our secondary measure shows that advanced care planning improves the perception of the quality of care received. Patients themselves, or their relatives if they are deceased, reported higher satisfaction with the quality of hospital stays. This is true among both the patients that were still living as well as those patients who were deceased, in which case their relatives reported the satisfaction based on the perceived perspective of those deceased patients. Finally, our additional secondary measure shows that Advanced care planning reduced the level of adverse psychological effects among the relatives of the deceased patients. At 3 months following the death of the patients, the relatives of patients in the intervention group reported fewer symptoms of post-traumatic stress, anxiety, and depression. Moving on to some strengths and limitations about the study. One of the strengths of the study is that randomized controlled trial in medical treatments in real-life settings are rare, especially in the end-of-life care context. Hence, the insights that the study brings is invaluable. Another strength of the study is about its generalization. The intervention implemented in the study is logistically possible in most hospitals in developed countries, so the findings from this study can be helpful in designing healthcare policies in other developed countries. A further strength of the study is that both the perspectives of the patients as well as their relatives were taken as part of the data collection. On the other hand, there are limitations to this study. Firstly, patients and their relatives provided responses to some of the questionnaires using sentences rather than on point scales. The researchers had to code those sentences into quantitative data in order to conduct quantitative analysis. This process may be susceptible to subjective bias, and the paper did not document any procedures they took to prevent or minimize this bias. A second limitation of this study relates to ethics. The authors did not mention any precautions or measures they took to ensure the ethical conduct of the study. This raises the question of how did they ensure those patients in the control group were not deprived of their rights to seek advanced care planning. And also, we know this from the fact that it's a single blinded experiment. Was it ethical to conceal information regarding advanced care planning from the control group but not the intervention group? In conclusion, implementing advanced care planning can effectively improve end-of-life care, and it is welcomed by most patients. Advanced care planning in this study was successfully delivered to 81% of patients in the intervention group. Only 4 out of 156 patients refused to participate. Advanced care planning is not constrained by medical staff availability because they are delivered by non-medical facilitators. Advanced care planning dispels the common myth or the misconception that patients are distressed by such discussions. Some other important takeaways from the study. Patients often have a poor understanding of their own medical situations and the potential medical cares they might receive. Hence, advanced care planning should aim to improve patients' understanding on this medical information as well. Also, it is crucial to let the relatives of the patients be involved in advanced care planning discussions. This family involvement is found to significantly increase the likelihood of patients appointing a surrogate during the advanced care planning process. Finally, some suggestions for future research directions. Researchers in other countries, especially developed countries, should attempt to replicate the findings in the present study. This will shed light on the applicability of introducing advanced care planning to other healthcare systems, such as in New Zealand. In addition, future research with similar designs should document ethical considerations more transparently, due to the potential ethical issues that such research might face, which I have mentioned a few on the previous slide. Thank you very much.